Hi everyone, our names are Jordan, Amelia, Stephanie, Nardi, and Madeline, and today we're going to be sharing a clinical trial that discussed the differences between dexmedetomidine and propofol for usage in intravenous sedation during third molar extractions. Third molars are most commonly known as wisdom teeth, and they're the molars that are located in the back of the mouth. They're considered impacted when they are surfaced and they don't have any room to grow. Dentists recommend 59% of patients to get their third molars extracted to prevent the mouth from infection, tooth decay, periodontal disease, and much more. The first drug intervention that this clinical trial used was dexmedetomidine. Dexmedetomidine and midazolam was combined to use as sedation for patients with severe bradycardia. It is associated with minimal to no amnesiac effects, and it is noted to preserve the respiratory rate and oxygen throughout operation and recovery periods, which would be perfect for patients going through their third molar extraction surgery. The second drug intervention used in this clinical trial was propofol. Propofol has the potential to cause a quick progression from conscious sedation to general anesthesia, with the undesired effect to cause cardiovascular and respiratory depression. Because propofol is more commonly used during these third molar extraction surgeries, the researchers wanted to see if there was anything different that they could use to replace it due to the decreased respiratory drive, hypotension, and dose-dependent bradycardia that was seen when using propofol during the surgery. How it works. During the third molar extraction procedure, patients are sedated intravenously, which allows for a rapid onset of the drug given. The patients in this clinical trial will either be given dexmedetomidine and midazolam or propofol, midazolam, and fentanyl. When dexmedetomidine enters the bloodstream, the alpha-2 agonist binds to the alpha-2 receptor, reducing the release of norepinephrine. The decrease of norepinephrine causes a state of sedation in the patient. When propofol enters the bloodstream, it binds to the GABA receptors, also known as gamma-aminobutyric acid, which then causes the GABA-activated channel to be open. Once the channel is open, an increased influx of chloride ions causes hyperpolarization of postsynaptic neuronal membranes, resulting in inhibition of postsynaptic neurons, creating sedation in the patient.
The goal of the research was to prove that Dex is the safest and most effective drug for patients to use for intravenous sedation instead of propofol, since it has severe side effects. The way they went about it was that the allocation was randomized, and they had two participant groups for sedation during third molar surgery. The first one was active comparator, which was the propofol group, and this included patients that administered propofol, midazolam, and fentanyl, while the second one was experimental, and that included the Dex group, which included patients that administered Dex and midazolam. The primary measurable outcome was the respiratory event requiring intervention during surgery. So they compared the group's rates of interventions for respiratory events such as jaw thrust, chin lift, Yonkers suctioning, tongue thrust, insertion of an oral or nasal airway, and administration of positive pressure oxygen. All in all, there were 332 completed studies. 296 of them were interventional, while 33 were observational. There were early phase 1 and phase 1, phase 2, phase 3, and phase 4. Early phase 1 and phase 1 were around 2%, while phase 2 was 19.8%, phase 3 being 11.6%, and phase 4 being 21.5%. The rest were not applicable, which was 43.6%.
This study was a randomized interventional study with 144 participants. The study began on March 20th, 2018, and completed over a year later on December 27th, 2019. As for inclusion criteria, the age range is 18 to 35, which is younger, but that is to be expected as that is the perfect age range for third molar extractions. Any sex was included, there must be third molars to be extracted, ASA class 1 or 2, and English-speaking or Spanish-speaking subjects only. As for exclusion criteria, any patient taking alpha-2 agonists or benzodiazepines were excluded as that could interfere with the administration of the drugs. Any allergy were excluded, a high BMI, any history of substance abuse or alcoholism, any mood-altering medications, or pregnant females were all excluded from this study. The study began with 144 participants, being broken out to a group of 69 for Propofol and 75 for Dex. These groups had very similar ranges from 50 to 19 to 46 to 29 female to male ratio respectively, age mean of 21 for both, BMI mean of 25 to 26 for both, and the exact same mean of teeth extracted for 3.6 for both. Again, the Propofol group had 67 participants and the Dex group had 74. Out of the 67 in the Propofol group, 17 patients experienced a respiratory event requiring intervention. This made up 25% of the Propofol group. Out of the Dex group, out of the 74, only 2 experienced these respiratory events, making up only 2.7% of the group.
For the interpretation of the results, we could see that the Dex group only had a 2.7% of respiratory events. On the other hand, we have the Propofol group, which has a 25.4% of respiratory event. This is almost a 23% difference between these two groups. We could also interpret this as if we're treating 100 patients with Propofol, 25 out of 100 most likely will experience a respiratory event. Or in the case of the Dex group, just 3 patients will experience a respiratory event. This is a big difference. I think this is the reason why in this experiment the p-value was not provided, and they didn't record any adverse events either. For supplementary study 1, we found this very interesting study in which they're using the same exact drugs, but in a different procedure. In this case, they're using the drugs in a awake craniotomy. For the primary outcome, they're measuring the ability to perform brain mapping as well as the level of sedation. They measure respiratory events as a secondary outcome. In our study, it was our primary outcome. Both studies were randomized control. In this case, they only had 50 patients as their population. They were divided 25 for one group, 25 for the other group. In our study, our sample was a little bit bigger, 144 patients, and were divided in 69 for Propofol, 75 for Dex group. In this study, they found 20% of the patients in the Propofol group had a respiratory event, versus the Dex group, which they reported 0% of respiratory events. This is consistent with what we found in our study, 25% versus 3%. For this experiment, the result of the brain mapping and the level of sedations were very similar. They didn't report any difference. The percentage of the Dex group in this case is very low, and it's because I think the sample was not large enough. In our study, the sample was a little bit larger, and that's why we found a larger percentage. For the supplementary study 2, we found this study in which they're using midazolam and fentanyl for pediatric endoscopy. Their goal was to find any adverse event with these 2 drugs. This was not a randomized control like ours. It was a cohort study, which means there was not a control group. 1,226 patients were studied under the same sedation. They found out kids younger than 6 years old are more likely to develop desaturation, which counts as a respiratory event, with a p-value of 0.01, which is significant. And out of the 1,226 patients, 2 of them had an adverse event. In this case was apnea. That's when you stop breathing while you're sleeping. Their conclusion was that this type of sedation was safe for kids over 6 years old. This is good for a study because the third molar extractions are usually for patients over 16 or 18 years old. So we're safe to use them.
Recommendations on how the clinical trial design, questions, or results can be improved. We could do a long-term follow-up, which is conducting follow-up assessments on the patients to see if there's any differences on how safe and effective the two treatments are even after the surgery is done. We could also do randomization, which is to make sure the experiment is being conducted fairly. Patients are picked randomly to get either of the two treatments, and this will minimize selection bias towards the patient and the researcher. And we could also do reports done by the patients. So for a more personal feedback, including the patients to state how the sedation felt, pain levels, and positive and negative effects to gain insight from their points of view. How our group feels this clinical trial can change treatments. This type of research has the potential to enhance patients' experiences during significant dental procedures, offering a valuable solution for individuals who suffer from anxiety and irregularly attend their appointments. We agree that Dex is a better option because it is more safe than Propofol due to having less respiratory events.
Attached here is a list of the references we used. Thank you all for your time and attention as we gave this presentation. This presentation and project was very dear to a lot of our hearts as we are pre-dental students and hope to go to dentistry very soon. I hope you have a great rest of your day and enjoy the rest of the presentations. Thank you.